Hi everyone, this is Howard sitting in for Jeff. Jeff and Travis are not with us this week. Seth is. Um, I'll start and show some cases. Can someone confirm that my screen is showing?
I don't see it.
Okay. How about now?
Yeah, now I see it.
Very good. Okay. All right. I'll start with this case. This is something I've shown before. Again, it's really just a lesson or an demonstration of how hard it can be to see lesions, particularly including lesions that are not that small. So this is going to be a hidden lung cancer. So this one is going back to 2005. And let me bring alongside 2011, which is here. That's a bedside radiograph. Let me go to the next one, which is May of 2012. And I'll just bring that up momentarily. So of course the task here is to look for a lesion and to see if you perceive it. Let me go forward in time to 15, so that's about 3 years after that. So again, alongside we have the comparison from February 05 and 15. And here I'll just make this one a bit big, like that. And just give you a moment to look at that. Forward in time now to February of this year, which is here. Give you a moment to look at that. And I will tell you that so far, no one raised the possibility of a lesion. So here I'll bring up alongside the one on the left-hand side. So now, of course, we do have abnormality. And I will tell you that at this time, the person had hemoptysis. Here, of course, we can see the lesion that has slowly grown over time. And the hemoptysis here was blamed on the fact that the patient was started on anticoagulation for an atrial fibrillation, I think. But here is the lesion. And again, it just points out that even when the lesion is relatively big, a couple centimeters, by virtue of its location here in the upper and medial right hemithorax, adjacent to mediastinum, adjacent to normal mediastinum, it can be really hard to perceive. Of course, there's a summation effect as well. The lesion is partly superimposed on structured noise, which is ribs in this case. But by virtue of its location, it's really hard to see, or relatively hard to see. So again, I've got quite a few of these in my collection, and sometimes I'm asked in the context of a medico-legal consultation, potentially about the failure to perceive things. And suffice it to say, I've seen this many times, and failure to perceive lesions that are in difficult places, in my view, clearly do not represent an error that might be characterized as a breach of the standard of care. And this is just one example of many that I've accumulated over the years. So really hard to see lesion. Here is the CT now, and you can see that it is quite large, but where it's located, and there's hemorrhage there, and just another lesion in hard to see lesions. All right, let me go on to show this one. So this is a unusual tumor in a young person. So just for the 23-year-old. At this time, the patient, of course, has a catheter in already, and we see the abnormal opacity in the left lower chest. And I will show you in a moment a CT that we had from the outside done a little before. But it may be an example of an opacity that doesn't go away. Perhaps it was diagnosed as possible pneumonia at some point in time. I don't really have detailed clinical information, but this is what it looks like now. So I'll scroll through that. And We'll see there are some slightly enlarged mediastinal lymph nodes, but here is the lesion. It's quite large. It's located in the left lower lobe. It is close to the hilar region. It's associated with a small left pleural effusion. And certainly, if it doesn't resolve and the patient doesn't have a pneumonia, we're concerned about tumor. In a young person, there's a big differential of the usual smoking-related tumors as well as adenocarcinoma, but other ones as well that are the unusual, non-usual bronchogenic carcinoma. So this turns out on a biopsy to be a sarcoma. And as you can see there, by virtue of this FISH testing for this EWSR1 translocation, that was positive. And also by histology, that's positive. So this is an unusual primary pulmonary Ewing's sarcoma in a young person. One can find case reports like that. It's obviously quite unusual. One can't really separate it from other unusual sarcomas or small round cell desmoplastic tumors and so on. But this one turns out to be a primary Ewing's of the lung in this patient. Okay, this is a really interesting case from several points of view. So this starts back in August of 2011. So I don't know what symptoms the patient had at that time, but here's the lateral projection that goes along with this. So that's a large mass. This is a person that is, don't have an age there, but I'll get that to you in a moment. Here is what it looks like on CT. So clearly a differential diagnosis for a large mass. That is certainly hard to separate out mediastinum for sure from pleural tumors. It's a little bit to the right of the midline, of course, in the anterior right hemithorax. Clearly very heterogeneous in attenuation, lots of vessels within this lesion. But this turned out to be a thymoma on removal and biopsy. So let me bring up the lungs now at that time, and I'll just scroll through there. So in addition to that lesion, let me make this one a bit bigger. Take a look at the bronchi and bronchioles. As I scroll through this, you'll see there's bronchial wall thickening involving multiple generations of segmental bronchi. In locations such as this, we see bronchioles filled with intraluminal material, areas of normal lungs, so patchy but still multilobar. Here again, the bronchi in particular and bronchioles are abnormal, filled with intraluminal material. So with that, let's go forward in time now. So here is the CT from 2012, which is really going to show the same things. Let me just bring that up real fast, scroll through there. So in addition to that, we see at this time there is a process going on in the right upper lobe, which is associated with cavitation. That's what it looks like at that time. And the lungs have some of the same findings I described before. So that's 2012. Here's what a chest radiograph looked like at that time. And here we go to 2013 now on the right-hand side. And you can see that that healed with some scarring, but there are some additional subsegmental sized opacities in the right lower lung as well. Let's go forward in time to 2014, and we see very similar findings. And here more recently in September. So now we see a lot of opacities in the right lung consistent with foci of scarring, presumably from multiple episodes of that, which is infection. So this person has had multiple infections, abscesses, treated with antibiotics, got better. I'm not quite sure why the right lung is more affected than the left, but pretty much the same findings we see before with very conspicuous bronchial and bronchiolar abnormalities. So this, the combination of repeated infections and the thymoma, goes along very nicely with good syndrome. So here are some facts about Good syndrome. It's the combination of, and Good described a thymoma with repeated infections. Typically, they have hypogammaglobulinemia. This is different from CVID. They have abnormality of both B cells and T cells responsible for repeated infections. And here is kind of an interesting statement that all patients with thymoma should have serum immunoglobulin levels measured, because sometimes, apparently, and I'm not sure I agree with that, but sometimes the infection part of things doesn't really develop until a little bit later. So if the results are in the normal range and there's a clinical suspicion of infections, these tests should be repeated. And as you can see there, sometimes it only becomes apparent a little bit later on. I think this might be the first or second one that I've seen of Good syndrome. Has anyone seen a case like this of Good syndrome, or what might be in retrospect thought to be Good syndrome?
I've never seen it.
Okay.
Howard, I think you showed a case before, a couple of years ago.
Oh, you've got a good memory. I can't remember if I showed another case, or I don't think it was this one, or did I? Does it look familiar?
No.
Or something like it?
Mm-hmm.
Okay. Okay. So this one came in follow-up the other day, and then I was reminded of it, and I went back and got all the imaging, as you can see here. So a really interesting entity, Good syndrome. So another one to add to the list when one sees a thymoma, in addition to, usually myasthenia and red cell aplasia and so on. Okay. This one is just the notion of a vascular abnormality. So a case like this might start off something like this. There's not much to see here. I'm going to show you or stress the fact, putting the thick slab MPR adjacent to this, that when it comes to making judgments about the size of the aorta, particularly the proximal and even mid-ascending aorta, you can get a fair amount of dilatation, as you can see here, which is not really apparent on radiography. So if you're lucky, you might see this interface. I've seen this interface, and sometimes it's not the aorta, but just the SVC and fat simulating a dilated aorta. But the point being that you can get, as you know, quite a bit of dilatation of the aorta, and particularly on the frontal projection. And if the patient has quite a bit of fat, you can't appreciate it. Here, you might be able to appreciate the dilatation of the aorta on the lateral rather than the frontal projection. So that's the finding. And the association here, I'll bring up the axial, is with the bicuspid aortic valve. So we go down there and we see calcifications in that bicuspid aortic valve. I'll bring in the coronal projection here to show the pattern of dilatation of the ascending aorta. This is the one I think we see most frequently, where the dilatation involves the right lateral wall of the aorta, this convexity of the aorta, and there is the notion of bicuspid aortic valve with an aortopathy. People talk about different fusion patterns, but the most common is the right and left fusion pattern, in which case the jet or the hemodynamics favors dilatation involving this portion of the aorta, this lateral portion, rather than this fusion pattern that tends to involve that portion of the aorta. And then other people more recently have talked more about the notion of bicuspid aortopathy. So the idea being that, and these people do talk about the fusion patterns, but they make a distinction between dilatation of the aortic root as opposed to the ascending aorta. So this one over here is an example of the one I just showed you. And then there is the notion of what they call the BAV root phenotype, in which between the aortic annulus and the sinotubular junction, we have dilatation. And they speculate that the former has got to do with hemodynamics, whereas there's increasing evidence that the BAV root phenotype is more genetically determined and has a higher incidence of subsequent problems. And this has a bearing on whether they're going to operate on the patient or not. So in this set, the one that I showed you, they make the argument that surgery may not be indicated, or you can just follow the patient, whereas people with the BAV root phenotype and aortic dilatation typically are operated on. So I think this is a nice example of bicuspid aortopathy, at least this kind of variant of it, the right and left fusion pattern. And again, here's what the valve looks like. And Seth, do you agree this is a right-left fusion pattern? Sometimes I can't quite figure it out in relation to where the left and right coronary arteries are, but it ought to be. Okay, those are my cases. Let's see, David and or Seth.
Yeah, I have cases now.
Great. All right.
So
Good.
this is a 52-year-old guy who came in with shortness of breath. He actually didn't come in with shortness of breath. That's a lie. He came in because he had a leg abscess, and he had to have the leg abscess kind of surgerized. So they did an echo, and they saw that the echo was very odd. So they sent him for a cardiac CT, and you can see that there's lots of abnormalities. The most conspicuous, I think, are the large right-sided aortic arch, the left-sided SVC, but then we also see that there is a large VSD here, which is I'll get in a 4-chamber view, kind of a supercritical VSD here, and then, or perimembranous. I actually usually use perimembranous. And additionally, there's pretty much absence of the entire septum, atrial septum. So he has an ASD, perimembranous VSD. He also has a pretty nice classic overriding aorta. You can see that the aorta sits over both the LV and RV here. So here's LV, here's RV, and it overrides the VSD. And go back, and then he has RV hypertrophy, which isn't surprising, and then this pulmonary stenosis, which is I can't remember if this was a couple of weeks ago, just supravalvular here. So here's and he also has some infravalvular narrowing as well. So here's the valve, and here's this supravalvular narrowing. So this is a pentology of flow, undiagnosed. And when I was looking at this, the surgeon, one of our cardiac surgeons, came in for another reason. You can also see all these collaterals, which then drain into the lungs, these bronchiaortic collaterals. But the point being is that he probably survived so long without any issue because of this, mild to moderate pulmonary arterial stenosis. So that basically balanced him out, whereas the high pulmonary pressures due to this narrowing here basically limited the amount of shunting across the ASD and the VSD, because the right-sided pressures were going to be higher than normal because of the stenosis. So even though he did, I'm sure, have shunting, the shunting wasn't as bad as you would think it would be. Presumably, that's why he was I can't remember if he was 52 or 62 without ever showing up. But just a nice case of pentology of flow. And another thing to notice with any of these conal truncal rotational abnormalities is that whenever you look at the aortic root down the plane, there's going to be clockwise rotation of the aortic root, which is the basic lesion behind the whole tetralogy phenomenon. So normally the non-coronary sinus should always point between the two atria, which is here. Because of this clockwise rotation, you can see that the right, which should be pointing anterior, is a little bit clockwise, and the left is more posterior. So anyways, pentology of flow.
So Seth,
Yeah.
So what's the fifth element again for us?
The ASD.
ASD. Okay.
So it's the VSD, the overriding aorta, the RV hypertrophy, and the some degree of pulmonary stenosis. Those are the four that's TED, and then the fifth is the ASD.
Great.
So this was interesting case we had before I went away. Pretty. Let me do this. Let me kind of thicken this thing up so get a little more. Move over out of the way. A little more, kind of less noise here. Let me do this. Sorry. And then. Blah, blah, blah. So this is a young 2-year-old that came in with dyspnea, and you can see that there's this large, very large mass, intrapericardial. There is an associated large pericardial effusion. The mass is extending basically behind the, narrowing the SVC, kind of going posterior to the aorta and anterior to the left atrium. And, you know, we saw this, and the surgeon came by, and I said, well, you know, it's interesting. We had a case that he remembered, and we talked about, because this is a case from about 4 years ago. I think I showed this one as well, where someone had a very similar looking tumor with a large pericardial effusion, same exact location, doing the same exact thing. This one was a little bigger, but nearly identical. This one was a little more cystic, but, you know, given the similarities, we really thought that this was going to be, I'll just play one. Oh, come on, man. Anyway, I can't get this to play. I can kind of scroll through and get it to play. This is the current MRI, but this thing was cystic. It had some areas of necrosis. It was extensively enhancing, and we thought it was going to be another mediastinal germ cell tumor. And sure enough, they biopsied it recently, and this was another mediastinal germ cell tumor, probably going to be, the path on it currently is a yolk sac tumor, which was exactly the same path as the other case that I showed that was from 4 or 5 years ago. So, you know, mediastinal or cardiac germ cell tumors are not common. They often are malignant, and some degree of, you know, you can differentiate depending on the hormone type based on both pathology and both on laboratory values. So when they tried to go in and look at this thing, it was just too big at the time. It was encasing everything. It was invading through the pericardium. So from my understanding, they sent the kid home, and they're going to start him on chemo to try to shrink this thing and then resect it and block in a few weeks or a few months.
So, Seth, what do you think? Where did it originate? Do you think it originated in myocardium or within the pericardium?
No, I don't think it's. So that's an excellent question. So these are often classified as pericardial. I don't think it's pericardial, nor did the surgeon. He thought it was invading through pericardium. I don't think that it is arising from the muscle itself. The question is, it's intrapericardial. That's for certain. Mm-hmm. The meat of it is within the pericardium. When I say in the pericardium, I mean deep to the pericardium, not between the two layers of the two mesothelial layers of the pericardium. So it's not a tumor arising from muscle itself. And then the question is, some people will still call this a pericardial tumor because it's deep to the pericardium but not arising from the muscle. But, you know, that's a different subclassification, because there are true tumors that arise within the substance of the pericardium. So I call this a cardiac tumor, although if you look at the history, it says cardiac/pericardial. So,
but not, it wasn't mediastinal and then went into the pericardium and ended up.
No. It was definitely, pericardium was all around this, and that's why there's this big effusion. So this was pretty much complete, and that's a fair point. We debated about that, but it is within it's deep to the pericardium.
Got it.
Yeah. It wasn't a mediastinal lesion. And I'll just to show that, I can see if I can get this to come over quickly without wasting time. So this is the old case that was very, very similar. And you can see, here it is, here's the pericardium, and this thing is wrapping around the aorta, the left atrium, the aortic root, but it's not mediastinal, it's within the pericardium. And on the MRI that we did on this patient, which there's just so many sequences to pull up, it's basically almost identical. You can see here, it's within the pericardium, surrounded by pericardial fluid. It's not mediastinal. But we spent time trying to determine that one way or the other. So the last case was a case we had when I was away, and it's interesting. I've seen, I think, de novo, a lot of left atrial myxomas, 4 right atrial myxomas, and 2 of those right atrial myxomas happen to be within the past month or so. And this one is interesting because it's arising, there's a stalk, a posterior stalk here, it's arising very, very, very high in the right atrium and kind of into the superior vena cava here. It's not along the fossa ovalis. We know that almost every single left atrial myxoma is going to arise in the region of the fossa ovalis. This right atrial tumors or myxomas, actually, the most of them do not, at least in my experience and some other people's experience as well. So for some reason, we got an MRI on this as well, which doesn't really show any difference, what we kind of expect with the lesion. Actually, final path is yet to be back. I should hold my tongue, but I can't imagine this being anything else but a myxoma. But yeah, so this is another right atrial / SVC-ish myxoma.
That's impressive. It's not really producing much in the way of obstruction. The blood flow is going right around it, down the RA, RV, and so on. Oh.
Yeah, and it's not. There was some obstructed SVC flow. I think they saw an echo, but no, there was not. And then I wasn't here, but Gene did a delay, which was good because we can see that this thing is clearly not a thrombus. There's all this enhancement within it, and these things do tend to enhance slowly, which would further support that it's a myxoma. But yeah, even though they're quite big, and they do tend to lead to, I have to say, the ones on the right I've seen tend to be a lot bigger than the ones on the left, and I think because the degree of obstruction tends to be less on the right, and thus they tend to be much larger before they become symptomatic. But I'm sure someone has written that, but that's just my own experience. Those are my cases.
Seth, can I ask you about a case that's floating around here now? We don't have a definitive diagnosis on. It's a man with tremendous aortitis. I think 53 years old.
Okay.
He's got this aortic wall thickening that goes from his ascending aorta through the arch and to the descending aorta. It tapers off somewhat in the abdomen, but there are still localized wall thickening in the lower abdominal aorta and even going out into the iliacs. It also, this arteriolitis pattern actually coats his right coronary artery as well.
Oh, wow.
And, he's too old for, Takayasu. He had some negative serology that's pretty good at excluding giant cell arteritis. And he's got a lot of lymphadenopathy in his mediastinum and hyla that looks just like sarcoid. You would say, anytime you saw that lymphadenopathy, you'd say this is sarcoid. And I'm just wondering if you've ever seen sarcoid arteritis, aortitis.
I have not. I mean, there's a lot of granulomatous arteritises. I don't know what the plural of arteritis is. I mean, there are some granulomatous processes that can cause arteritis. But I have to say, I have not seen the combination of sarcoid and a vasculitis like you're describing. I don't know if I've ever seen sarcoid in a large vessel vasculitis in general.
I found a couple of case reports of aortitis in the setting of sarcoid, but just a couple.
Yeah, we all seen a ton of sarcoid, and
yeah,
yeah, I just haven't seen that before. I'm sure it could happen. I just haven't seen that before. And, you know, it's interesting. You know, there's all this IgG4 stuff and sclerosing periaortitis and all these other kind of newer diagnoses.
Uh-huh.
And they're often diagnosed via serology or just kind of biopsy.
Okay.
And I still don't know how to differentiate between any of them. They all looked like just like large vessel vasculitides.
Got it.
And I mean, I don't know if anyone else has any better clue. I struggle with those all the time.
Okay.
And nothing on the kidneys or otherwise to suggest some weird, I don't know what, Erdheim Chester can sometimes do that.
Evidently, Rosai-Dorfman can have a vasculitis component. I haven't pulled any literature on that yet, but that just came up late morning as a possibility. Yeah. Given the substantial lymphadenopathy that's here and the very clean look to it, it doesn't.
Yeah.
Looks like sarcoid or.
There are probably a lot of case reports out there in the literature of entities like that nowadays would probably be diagnosed as IgG4 sclerosing disease rather than any one of those other things.
Okay.
Matter of
I haven't seen systemic histiocytosis or lead to, but I've seen like one case of Rosai-Dorfman, so I'm not sure exactly what it can do.
Can the aortitis be pretty impressive with IgG4?
Yes.
Okay, I'll bring that up with the clinicians then.
And I still don't understand it. And it's basically, to me, IgG4 and Takayasu's and look identical.
Okay.
There's no way. I don't know how they make the diagnosis, but so here's the issue, and I'm talking to our vascular pathologist. He says with chronic inflammation, if you can test with certain staining for IgG4. And the issue is that it's one of these kind of things that's become very trendy. And with any severe chronic inflammatory process, you do get increased levels of IgG4. And in the true cases that you see, it's just like it's just extensive staining with whatever stain they use. But now you're getting these people with a non-specific vasculitis, they get a biopsy or something, and someone puts a stain in, there's a couple little areas that stain positive, and they call it IgG4 vasculopathy, whereas with Takayasu's or giant cell or all these other ones, if you stain it for IgG4, you're going to have little areas that are positive. So, it's like one of these just new entities that everyone's kind of loving to call, but I would definitely test for it.
Yeah.
Okay.
Isn't IgG4 usually more a periaortitis than an aortic?
Yeah, they talk about the sclerosing periaortitis, but I've seen both.
Okay.
But you're right, but it's most commonly the sclerosing. It involves predominantly the ascending aorta, and you can get calcification in the wall. You're right, that's classic.
Okay.
Good.
Howard, I found your good syndrome case from 2011.
Is it different from the one that I just showed? Just to clarify.
You want me to show it to you?
Yeah, because for some reason I don't think I had it in my teaching file, or I didn't put it there. So if you have it available, I can switch over to you. Would you like to do that?
Sure.
That'll be great. Okay, here we go.
Okay.
Yep.
Can you guys see a CT and a chest radiograph? Is this the same case?
I'm trying to show us some more.
Okay, this is CT from 10/14/11. I noticed that the dates on your case were 2016.
Oh, but I had some from 11, so I think it might be the same one that I got a more of an update to. Well, no, I'm not so sure, actually. That's from 11, huh? It looks a little bit different. And this is obviously post-op, so we have the stenotomy.
Okay, let's go back to an earlier.
That's in 2011.
So this is 03 with a port catheter in place.
03. Oh, if that's for sure 03, then I think it's a different one.
It looks as if there was already
nice bronchial findings. Bronchial findings.
Would you like me to send you your case?
Oh, yeah.
Yeah, send me his case too.
Yeah, yeah, that one too, because this is quite unusual, and I'll make sure it's the same one. But the one I just showed started in 2011, I think, rather than 03.